joining today's Alberta Transplant Institute seminar series. So my name is Ben Adam. For those of you that don't know me, I'm a pathologist here at the University of Alberta Hospital. Happy to moderate today's session. Just starting off with a few housekeeping items. Starting with the land acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. A couple other housekeeping items. First of all, thank you to Astellas for their support of the ATI seminar series. And just a reminder that the 2026 ATI Research Day will be held on March 25th, and we are pleased to have Dr. Kieran Cush from Stanford as our keynote speaker. So please register and submit your abstract and encourage your trainees to present their research. And I think Sadie is going to paste the link to that event in the chat. So without further ado, I'm happy to introduce our speaker for today, Dr. Massimo Mangiola. Dr. Mangiola holds a Ph.D. in clinical and experimental immunology from the University of Genoa in Italy. He is an associate of the American College of Histocompatibility and Immunogenetics. Dr. Mangiola has more than 15 years of experience in transplant immunology. In the United States, he has trained at Tufts Medical Center in Boston, and has directed or co-directed HLA labs in Boston, Providence, and Pittsburgh. Currently, Dr. Mangiola is a clinical associate professor and NYU Langone Immunogenetics lab director at the Transplant Institute of NYU Langone Health in New York City. He has served in several committees, is the current scientific curator of the HLA eplet registry. He is active in research and has published in peer-reviewed journals. And Dr. Mangiola is actively investigating the role of molecular HLA mismatch in solid organ transplantation and the immunological barriers to porcine xenotransplantation. And the title for his seminar today is Molecular Compatibility for Solid Organ Transplantation. So with that, I'll thank you very much, Massimo, for being here today.
Absolutely.
And I will hand the mic over to you.
Okay, so we molecular compatibility, I guess everybody knows these words. So we're gonna try to figure out today what does it mean and what does it mean to the patient, more importantly. Those are my conflict and disclosure. I have none for the presentation. And I want to start with the role of HLA in allograft survival. I guess we all know what HLA can do when the differences between HLA is not taken care of with suppression. But I like to put some images to it to just give you the extent of the role that HLA has in transplantation. And I always love to show these slides that are from related living donors, those are sibling transplants that we all know would be the best option for our patients, so the best organ to avoid rejection. And those are slightly old in terms of short and long-term outcome, but they still make the point, which is what I want to do. And you can see from point one, on the left-hand side, you have the short-term early rejection. This is mostly driven 12 months post-transplant, and on the right you have the 12 years post-transplant. And you can see the difference was statistically significant between zero mismatch and more than non-zero mismatch at the ABDR. And you can see in both sides that the difference is statistically significant on the probability of having early rejection or late rejection. And then you can see that in point number 2, that as you increase the mismatch between the patient and the organ, that the probability of having short and long-term rejection increases. And there is a thing about the sensitization of our patient and the transplant rate, so the probability of our patient to get an offer. This comes from the SRTR, it's slightly old also this image, but it's still accurate, it's still true. And you can see, apart from this peak of offers, 99.7, you can see how a decimal point changed in the CPRA, how sharply the decrease in transplant rate is for our patients. So sensitization is very important. And actually, this thing did not improved that much in the US after the UNOS applied the new CAS, the new allocation system. They're still very disadvantaged. And we know that waiting on dialysis is really not a great option in terms of survival for our patients. You can see right here that dialysis only is really not a good thing. That's the reason why we are sort of forced to do this sensitization treatment on this ICA-PRA patient. But what is the problem number two? One of the problems is that every time we put an organ into a patient and this organ is rejected, there is a very high probability that the patient start develop sensitization to the organ. And so if we keep on putting organs on this patient, what we are doing to this patient is to increase the CPRA. And I guess this is the perfect crowd to speak about the impact of the CPRA in organ offers. So what can we do to increase the longevity of the organs? So what can we do to improve the outcome and keep our patients on the low end of the CPRA range as opposed to the higher end of the CPRA range? And to me, and it's very obvious that the solution is to decrease the molecular differences between the HLA of patient and donors, because if we do so, we reduce the probability of generation of HLA antibody and cellular rejection for that matter. But what is immunogenic in the HLA molecule? We all have HLA molecules. Is the most important antigen protein in for our immune system. So if we compare recipient and donor, these are two pretend HLA molecules. On the left, you have the recipient, right of the donor. There is a lot of similarity between the HLA that we all have. And here is represented by all these magenta areas. But the HLA molecule is one of the most polymorphic molecule in the that is known. I mean, the genes of the HLA system are the most polymorphic that we know of. And there are some hot spots in the molecules here are represented by these yellow patches where the amino acids are different between recipient and donors. Now, it so happens that the immune system of the host or our patient can detect those differences, and they are potentially immunogenic. So they can lead to cellular and humoral rejection. So let's see to understand like the mechanism and why we want to study and how we need to study this. We need to look at the mechanism, the cellular mechanism of primary immune response. T cell gets activated by detecting peptides that derive from mismatch HLA antigen in the organ. And when the T cells get activated, some of them become follicular T cells and they move to the spleen. This is the T cell activation part. Sometimes concurrent at some point in time, the recipient B cells can detect mismatch HLA antigen and through the BCR binds to the epitope. And when that happens, they get activated and they move to the spleen. In the spleen, T and B cells meet again in the germinal center, and this is the T-B cell crosstalk, very important. That's where we use belatacept to stop this crosstalk, because when this crosstalk is efficient and when cognate T and B cells meet in the germinal center, the B cells are pushed into plasma cell, and plasma cells are the antibody producing cells. And so we have now antibody production. And of course, one of the components of the T cells activation is helper T cells, which will push the T cell side, so the T cell rejection. This crosstalk in the germinal center is incredibly important and also is incredibly regulated. The mechanism of crosstalk was discovered by Dr. Lanzavecchia in the mid-80s. And he was able to show, as you can see on the right-hand side, studying tetanus-specific T and B cells, that as compared to clone 7.1, which is B cells non-specific to tetanus, when you co-culture T cells specific, tetanus-specific T cells with tetanus-specific B cells, the T cells get activated with 10 to the fold lower antigen concentration as compared to the activation of T cells when they are cross-talking to a B cell that is non-tetanus specific. And he did call this linked recognition, which is incredibly important for the generation of the antibody. And blah, blah, blah. The bottom line of this concept is that in the germinal center, an HLA-specific B cells has to meet a T cells that has the same HLA specificity, right? So it was activated by the same molecule. This is also known as the carrier protein theory, right? Which is actually used in many vaccines that we use today, where the activation of the T cells and the B cells is much more potent and efficient when same meet the same. And so this is very important because the generation of antibody is still a T cell dependent mechanism. So if the interest of us is to score the risk of allo-immune response in our transplant patient, we cannot just look at it through the lenses of the B cell activation because it's just half of the story. And we were able to show that in early papers, which were done in a pediatric hard cohort, where, and we'll talk just like a little bit more later on this thing, where we found that among this cohort, there are patients that were transplanted with organs where the T cells and the B cell score do not match. So one says it is low, the other says is high. And you can see from the slide here, these particular lower risk transplants are less likely to form antibody because the two cells of the same kind are not present. So, but why are we getting into this thing? I mean, we have done transplantation with a conventional matching, so antigen allele matching for the longest time. Our patient gets transplanted and everything seems to be fine. But I want to go back to the fact that we need to increase the longevity of the organ for at least two reasons. One, there is not enough organs out there for all the patients, at least in the United States. And two, every time we lose an organ because there is inferior compatibility, we increase the probability of, we increase the CPRA, which decrease the probability for the patient to get an offer. So if we have a patient, for example, and there is donor 1 and donor 2, and these are made up HLA antigens, donor 1 and donor 2, from the antigen standpoint, they're identical to each other. They are both one DR mismatch. They are 15 on donor 1, they are 17 on donor 2. But it's easy for me to show you that actually by the molecular compatibility, donor 1 is actually 80% more similar than donor 2. So if you have the opportunity, you should have, and we should have transplanted our patient with donor 1. Why is that? As you know, the HLA nomenclature, so the number by which we call these antigens, has nothing to do with how similar or dissimilar they are at the molecular level. It just when they were discovered, A1 first, A80, the 80th. So if we find another HLA-8, we're gonna give it number 81. But this numbering system and the proximity at which they are in terms of number speaks nothing in terms of how similar they are to each other. In fact, I can show you that on top by eplet mismatch and below by peptide mismatch, there is absolutely no correlation between the number of the HLA and the mismatch between one and another. As you can see, actually A1 is more dissimilar to A2 than A80 for that matter. And so the molecular makeup of the HLA molecules is what really speaks and tells you about the potential immunogenicity that these molecules have. And I give you an example of that. Here there is a candidate we had not too long ago and an unrelated donor. This is a solid organ transplant. And when you look at the allele mismatch or allele match between them, you can see that it's only 4 out of 8 allele that are matched to the patient. So by any means, by number, especially if you look at the fact that there is 2 allele mismatch, HLA DRB1, that this donor is most likely not very molecularly matched to the patient, but actually it's not true. This patient has a low risk for T cell activation, and actually the DRB1 is only 2 mismatch peptides, and the B cell is also low risk with the highest DR mismatch being 3 eplets and the highest combo DQA and DQB being only 6. So molecular compatibility is a biomarker for identification and quantification of potential immunogenic difference between the HLA molecules of the recipient and the donor. And that's the best way to compare a patient to a potential donor when we want to know what is the probability that we are feeding the immune system of the recipient with information that are very relevant to the allo-immune response. And these days, lucky us, we have a number of tools that will allow us to determine to quantify these differences. And we have PIRCHE-II that is a risk calculator for the activation of the CD4 T cells. And it's called T2 because it looks at MHC2, which is what is the mechanism by which the CD4 T cells looks at non-self peptides. And then we have the actual eplet registry, and actually now PIRCHE offer also the model PIRCHE-B, which can calculate the probability of the patient's B cells to see a non-self epitope and be activated. So we're going to look at how these two modules work and what is the information that we get from them. So again, PIRCHE-T2 is the prediction of activation of CD4 T cells. So you can predict what is the likelihood that the CD4 T cells will be activated given mismatch peptides that they're coming from the HLA of the donor. The PIRCHE has a couple of modes. There is the clinical mode and there's the lab mode. The clinical mode calculates these for ABC, the RB1 and the QB1. The lab mode, if you switch this one to lab mode, you can do the calculation on all of them. The reason why this difference is that there is a lot of literature and correlation for ABC, the RB1, the QB1, and PIRCHE is working with several teams across the globe to find stringent correlation for all the other loci. The first step for PIRCHE is to estimate, to try to figure out which one are the peptides that can be derived by the mismatch HLA antigen in the organ that, of course, are non-self. So these peptides are not present in your own HLA. The step 2 is very, very important. And the question is, which one of these peptides can actually be presented in the MHC class 2 of the patient, right? This is a self-restriction. And this is very important because you can have 20 peptides derived from this molecule, but only 5 of them or 3 of them can be actually presented in the MHC. And so for those that can be presented in the MHC, the calculator is going to give you a score and it's going to say like, there are 3 peptides derived from this molecule, there are 7 derived from this, and so forth and so on. Now, I'm sure that you all have heard a lot of fuss about these risk epitopes, 2 mismatch, 1 DSA, all this theory where we are actively trying to understand and figure out whether something is more immunogenic than the other. Well, I personally do not believe that something is more immunogenic than the other. I think every mismatch is a risk mismatch. Anything that is non-self has the potential to be detected. This is what our immune system does. It's been built to detect differences. So to me, it's more like how the differences are presented, in which context they are presented, that makes something be more likely to be activating the immune system. I'm going to speak a little bit about this. So the mechanism here is that somewhere in the periphery and perhaps in this drainage lymph nodes outside the organ, a naive T cells sees a peptide that has never seen before presented by the APC of the recipient and gets activated. Moves to the germinal center, and in the germinal center, these T cells will be presented again with a peptide, but this time the presentation is through the B cells that have been activated before, as I showed you, and they move to the germinal center, right? Step number 1 is that these peptides must be derived from the same molecule, right? They don't have to be the same peptide, but they have to come from the same molecule. This is the theory of Lanzavecchia. When that happens, it makes it for a functional T-B cell crosstalk, right? And so you remember the figure from Lanzavecchia, you need much, much less antigen to still have a very potent response from T cells. So T cells and B cells start crosstalk, And this crosstalk sends the B cells into maturation, into plasma cells, and development of very highly specific HLA antibody. What these two mechanisms also have in common with each other in two different places in the immune system universe is the MHC restriction. So which peptide can be actually presented and how efficiently peptides can be presented by the MHC class 2, which is something that PIRCHE gives us. And so I want to make a scenario for you and say, suppose you have a donor that is DQ7, and then you have 5 potential donors, one expressing DR1, 15, 11, 4, and 17. And we're asking how many peptides derived from DQ7 can actually be presented by this class 1, class 2 MHC. And if you do a calculation, you can see that DR1 can actually present 31 peptides from DQ7, but the DR17 only 9, right? So this makes the DR1 perhaps a higher percent, a high risk presenter is very good at presenting peptides from DQ7, and the DR17 is much less of a risk in that sense. So if you have a donor that is DQ7, DQ4, you give one organ to a DR1 patient and one organ to a DR17 patient, which will have these differences in how much they can present. And you have the DR1 individual actually forming DQ7 antibody, but DR17 does not form DQ7 antibody. What does it say about the DQ7 immunogenicity? To me, no, nothing much, because we are not looking at the same context, right? So in the germinal center, the T cells and B cells of these two individuals did not have the same probability of finding each other if, in fact, this presentation still stands. And so it is important when we look at like immunogenicity that we keep in mind that we need to have a normalized population when we want to talk about immunogenicity. I don't know how easy it is for us to find enough N to pull that off. But the report from PIRCHE look like what you see right here on the screen. On top, you have the HLA of patient and donor. What you see red is what is mismatch. And PIRCHE is going to give you the total mismatch by for this donor. And for T2, so this activation of CD4 T cells, and for B, activation of B cells. Underneath, you have the locus specific. So now we are getting into the details, nitty gritty, where you can see what is the contribution for each and every one of the loci. And of course, to get even to the next step, which is very important, is we need to build from. You can go deep and figure out like what is the contribution from every single allele. So here, the DR17 is the presenter, and right here is the presenter allele. What this is telling you is that the DR16 contributes with 1 peptide, 8001 with 9 peptides, and so forth and so on. This is going to be the list of all these mismatch. And so you can drill down to see how many, what is the contribution for each and every one. So this is similar to what we are used to see in the eplet mismatch world. You can actually check which peptides, if you want to do some sophisticated analysis about which peptide might be more present, more expressed, and so forth and so on. So you can go to very, very, very deep details in these. And of course, when you switch to the clinical modes, it's going to show you also the RB3, 4, and 5A, DQA, DPA, and DPB. Another very important tool that you can use with the PIRCHE is the RAMP. It's like a risk score type of information right here, which we use fairly, we use a lot of times in here. I want to tell you what the way we use this information for. What this is telling you, and I'm just showing you the T cell risk, so the PIRCHE-II, you can select whichever population you want. There is the entire NNDP, or you can go by population, or you can, in the United States, we can use the UNOS information. So you can go to your actually total UNOS, or the region from where you're from. And what it's telling you is that for this particular patient, the average PIRCHE-II score in this case was a European individual. So I did check the European NNDP just because of the size of the genetic info. And for this person, the average PIRCHE donors out there has a score of 51. You can go drill down to the individual alleles if you want. And it's telling you that more than 50% of these bucket of donors are donors that have a score between 48 and 92. What is this information? What is telling me? Like, I'm sure that every one of us, at least everybody in this call that is in the HLA space, has been asked, is this a good donor? Right. So if I have an offer and the donor score for that offer is 75, and the medical team is asking me, is this a good molecular match, or the recipient is likely to have a better offer? I can see from the screen that the likelihood of having low is very low, and the vast majority is in these buckets right here. So it's actually not a bad offer, but it's in the middle of the pack. However, if the donor offer that we get is scores 20, and I get the same question, and the medical team is asking me, is this a good molecular match? How can you get a better offer? I can say, no, this is a unicorn type of stuff. It's in the lower end. Less than 10% of the NADP European population has actually a score of 20. So this is actually a very favorable molecular mismatch or molecular match organ, right? So we use it. I use it as a much more scientific way to prove, given the fact that that I can guesstimate the allele frequency on the population, but because there is no correlation between alleles and molecular mismatch, the allele linkage is not useful at this point when your question is about molecular compatibility. Another tool that I use very much from PIRCHE is the T memory, and I'm sure that everyone in the HLA space has heard that the thing before. For this patient, let's avoid previous mismatch. And I want to remind you that at the beginning of this talk, I spoke about the fact that HLA molecules actually have more similarity than dissimilarity. I think for another study, I did check what was the homology of the most mismatch, two of the most mismatched HLA, one from A, one from B, which was like over 90% similarity. So there is more similarity than dissimilarity in the HLA molecules, right? For that reason, it's obvious to imagine that there is a lot of sharing of peptides between molecules. Well, PIRCHE has a way to kind of estimate that similarity and that contribution. I'm showing you just HLA. Of course, it does it for all the major allele, both clinical and non-clinical mode. And so if you set up the previous mismatch, in this case, my previous donor was 3 and 11. So you set up, you get shaded right here. What PIRCHE does is to create this TMEM score. So it's predicted T memory. And what it's telling you is that there is probably sharing of peptide between that. What is this telling you is that if you get an offer and the new donor is 831, like that good old stuff of saying, well, I know crossing repeat mismatch doesn't stand very much in terms of peptides, because 831 is predicted to have TMAM. What it means is that 831 shares peptide with either 830 or 811 or both of them, right? And what this is telling you also is that, for example, if your new donor is A1 or A36, there's absolutely no predicted T memory. So that's be a favorable cross to do. And you can go even and be a little bit more fancy where you can say, look, the A2 group has less T-MEM prediction as compared to the group 31, 32, 33, and 34, right? So you can kind of quantify why. Now, why is this so important? It could be important in the situation in which your medical team has to consider perhaps reducing induction. It's asking you, like, can we reduce induction? I mean, this is a much better way to decide to reduce induction as opposed to, yeah, I think we can reduce induction, right? So not only you can say which one have the T memory holes, right? But you can also quantify that crossing A2 seems to be bringing less T memory as compared to crossing A33. All right, eplet mismatch. Eplet mismatch is the prediction of B cell activation. All right, so what is the likelihood that the B cells of the host will be activated given the mismatch HLA antigen in the organ? And before doing that, I have to talk a little bit nomenclature here because there is a mixed match of use of epitope, eplet, and what they mean to each other, what this relationship between them. So the epitope is where the antibody footprint binds, right? The epitope composition is for them is for the most unknown. So by that I mean which amino acid are contacted by the hypervariable regional IgG is no, it's not known. And whatever epitope you find over there is at best theoretical. We do not compare recipient and donor at epitope level because we don't know which amino acid to compare, right? We don't know which one are relevant to the IgG. So my recommendation is to use epitope when you speak about antibody binding to something, for example, a Luminix pattern. The applet is the functional part of the epitope. So in fact, it was initially called functional epitope. It appears to be the most important contact point for the IgG, right? So in fact, to confirm an applet, we do mutagenesis analysis on this amino acid, one or more amino acid, right? This is how epitopes are, applets are confirmed, right? By doing mutagenesis on those, you lose the reactivity IgG. Now, we do compare recipient donors at this level. In fact, this is where applet mismatch load is coming from. So please use applet when you're speaking about comparing a patient and a donor in terms of the molecular similarity. The other thing is that there's been a lot of interest in trying to harmonize the use of molecular match, molecular mismatch, and all these things right there. But I don't know in your center, but I believe me when I say that in my center, half of the medical team is going to ask me, what's the match between these two? And half of the medical team ask me, what is the mismatch between these two? So I personally I always try to be useful, and so I respond to the question using the same jargon that's being used by the medical team because that's the way they digest the information. So if somebody's asking me for the match, I speak about the match. If they ask me about mismatch, I speak about the mismatch. I don't think there is a better way. You decide which one is the best way in your center. The B cell applet mismatch calculator looks at all the loci. The ABC is calculated together because there is a tremendous amount of sharing of applets between HLA A, B, and C. So it's the RB1 with 3, 4, and 5, and all the others are calculated individually. The output look like this. On top, you have the HLA of patient and donor. In the middle, you have the total applet mismatch with the breakdown by loci. Those there are calculated together. And then underneath, you have the nitty-gritty of the information. The mismatch applet are listed in blue. Whatever is in bracket is antibody verified. Whatever is not verified. And then underneath, you have the individual contribution for every single allele, where you can see that, for example, in this case, O201 is the one mismatch allele that brings the most mismatch in this transplant. So if you want to do some analysis like that, you can do that. And this is where we identify the risk for this organ based on what has been published by Chris Wiebe and the Nickerson team. Of course, the applet mismatch calculator is kind of agnostic, so it doesn't do the calculation for you, just brings you the information, but you know how to do a calculation. And this which brings to the risk score, because there's been also a little bit of confusion as to how is the calculation made to do this low, moderate, and high risk grouping that was done by Dr. Wiebe. The Nickerson and Wiebe team, they published two papers. The first one, this one, 2017. This was the total DR and DQ applet mismatch, where they tried to predict the probability of developing DSA given trough level, so whether or not the patient has been compliant. And this is the paper that they used. It was one of the paper that brought the camels back. I mean, this clearly showed that there was like a direct implication of crossing certain stuff because it was looking at non-compliance patient. And then this is where the total DR and DQ mismatch less than equal to 11 is coming from. But obviously, Chris was thinking about the fact that when we form antibody, we don't form antibody to the entire mismatch DR, right? We form antibody to individual molecules, maybe more than one of the DR bundle, but not to all of them, right? So making a total mismatch is not really what happens. It's not what the immune system see. And rightfully so, the team did a new calculation with the 2019 paper where they look at the single molecule contribution. So what is the contribution in terms of mismatch load from each and every one of the mismatch molecules? This is where the low, moderate, and high applet mismatch comes from. And this is what we use for the calculation how mismatched at the molecular level our organ is to our recipient. So it is very, it happens frequently, it's not infrequent, let's put it this way, that you do a calculation and the total mismatch is 13, which by the total DR equivalent mismatch load means high risk. But when you look at the individual contribution, this donor is actually a low eplet mismatch, because as you can see, at the single molecule, it fits the criteria that was defined by Chris Weeby and his team in 2019. So this is not a mistake. This actually happens, and it could happen more frequently. So of course, in those patients, they are borderline between the low and the moderate range. So let's look a little bit of literature. Where is all this coming from, right? And you know, probably you know, but there is a tremendous amount of literature that proves that this mismatch, this single or multiple amino acid mismatch in the HLA molecule, directly related to humoral and cellular rejection. Pretty much you can find a paper in every single organ, actually include a stem cell transplant. And you can choose your poison. You can choose your poison as to what you want to read about this. I wanna suggest this paper, not because we wrote it, also because we wrote it, but not entirely because we wrote it. But it's a very good summary of where we are with these things, starting from the scratch, from like the background information about molecular compatibility, and then it finishes off with how can we use this information in transplantation, and what is closer and to happen and what is already been in use. For T-cell molecular, I love always to start with this paper, where the team they compare PIRCHE with ELISpot. And ELISpot is the gold standard of test out there for proving T-cell activation. So much so that this is a mandatory assay when you do vaccine trials in pretty much everywhere, in the US for sure. It's called ELISpot because it has these cute red spots right here. Now, the reason why I love to show this paper is that if you look the Kaplan-Meier's between the PIRCHE-II and the ELISpot, you can see that the endpoint of the Kaplan-Meier is almost identical to each other. So the prediction that PIRCHE made for the activation of the T cells was almost perfectly confirmed by ELISpot. So much so that, to me, PIRCHE-II, with all the limitation of computer assays, is a very good in silico T cell activation assay. I have done ELISpot. I don't want to do ELISpot, but PIRCHE gives me this opportunity. Nothing is perfect. The Luminex single antigen beads that we use every day is not perfect. So I don't think we can complain about the imperfection of this system. Another very consequential paper is this study on more than 400,000 transplants. So this is RTR data, where the team, I'm going to break this figure down for you, correlated the T cells on the x-axis and the B cell on the y-axis activation probability in 10, 5, 10, and 20 years survival. So is the organ still alive 10 years after? That's what this figure is showing. To make this figure slightly easier, so this left corner right here is the best case scenario. This is where patient was transplanted with an organ that is low PIRCHE score and low B score. And this is the worst case scenario. The top right is the worst case scenario. This is where both T and B scores are very high. And you can see that as you move from the left corner to the top right corner, the probability of having a functioning graft at 10 years decreases, right? So there is this is telling you a lot of things as to the fact that the scores are important if you look at them horizontally and vertically, but if you look at them longitudinally, like diagonally, if you wish, you can see that the contribution of two things makes things worse together, which is what I was speaking to you before. The paper that really completely changes the way, we look at matching, at least for us, was this paper from Chris Weeby and Nickerson. This is the total eplet mismatch where they compare non-compliance, right? And the probability of developing de novo DSA. And I just took a snapshot of the four. So those are people that had like less than 4 nanogram milliliter trough levels observed for more than 75% of the time. And you can see that these two buckets, the green and the red bucket, had pretty much the same amount of subtherapeutic immune suppression. However, the red ones, which were the high-risk donors, so the RNQ more than 11, did develop DSA. However, the one that had low-risk donors, so the one that had 11 or less, they did not develop actually DSA, despite the fact that they were not compliant. And this was to us huge because that immediately made us think, whoa, can actually immune suppression be reduced safely? And we'll talk about this briefly toward the end of this presentation. The other thing that was very huge was the follow-up of this paper, the single molecule contribution, which is the paper where we were able to see that as you increase the molecular mismatch, so does the probability of developing T-cell rejection, de novo DSA, and ABMR. And this is where the classification of low, intermediate, high comes from. Hey, we have a in-house experience. Dr. Montgomery is a transplant. He received a heart transplant a few years ago, and he did make this calculation on PIRCHE and B cell, and he was right there at crisp on the borderline. So it did reduce the immune suppression, will allow him to go back in the operating room. He's so happy now. In fact, he has moved on to do xenotransplantation now. Now, B cell, T cell activation, the crosstalk is very important. We believe that the best way to look at the probabilities by combining these two efforts. We published a couple of papers with the UPNC team, where when you look at a cohort, you see the low risk, they are both low. You see the high risk, both calculations are together, like they are high and high. And you can see that those guys are the ones that are more likely to form a rejection, de novo DSA. But then there is this group of patients that are transplanted with organs where the two algorithms do not match. So T cells is low, B cells is high, or vice versa, high and low. And when we did ask what is the probability of this individual to form de novo DSA, they were actually much less likely as compared to when they were transplanted with an organ that has both high and high risk scores. So there is a thing whereby, which is like the antigen presentation that I was telling you that was discovered by Lanzavecchia. One of the other questions and problems and comments from the field was, can this be actually segregated to populations? And so we look at it. Do eplet are more common in certain populations than others? And we use the CIWD 3.00, right, the database for the common, intermediate, well documented. So this figure is slightly complicated, but it is all the alleles that we know that they are in the CIWD database. And what we ask over here is, what is the expression of the HLA allele in these 6 populations? You can see by the color that the vast majority of HLA alleles that are in the CIWD 3.00 are rare in the world population. But if you flip it and say, like, okay, what is the eplet expression so in the population? And you can see by the color that the vast majority of the eplet, especially in the RB1 and the QB1, are common in these 6 major population groups, and actually they are expressed also by the most common allele in each and every one of these populations. So because we didn't believe that there was a contribution in terms of equity and ethnicity specificity, we wanted to test whether this stands still in the allocation system, right? So we took about a 5,200 individual population, and we created 20 random pools of 1,000 to match exactly the UNOS donor population cohort, which you see in the chart part right there. And then we compare the probability of finding a good match by the current UNOS method versus the eplet mismatch. And what we're able to show is that actually doing the eplet is more fair for minority like Black and Asian and Latinos as compared to zero ABDR antigen mismatch, which speaks about what I said before, that those eplets are actually more common than the alleles. And lastly, I want to show this paper just came out like in October 2024, more than about 5,200 kidney from the French Paris cohort. And I tell you, they have one of the richest database in terms of clinical information that they have. There were 33 clinical parameters that were included in this study. And what they were able to show that as compared to what they call evolutionary divergence, this is the difference in alleles, class 2 molecular mismatch at the RNDQ were the one that had the strongest association with AMR. So there is plenty of evidence over there to talk about the relevance of these mismatches. Let's talk about cutoffs, because we all need cutoffs, especially our clinicians. They love cutoff. We all love cutoffs. I want to warn you that the only risk-free situation is when your patient is transplanted with a zero mismatch, ideally from a related genetic match. So not only just a genetic match, but related on top of it. Any other scenario, you will be crossing the immune system. And you do not know, and we cannot know what that means. So if you get, or if I get a question where which one is the best donor, my answer, I don't know which one is the best donor. All I can do is to quantify the difference between the different donors. I cannot possibly know what is going to happen in 5 years from now. I can only tell you what I see right now. And that's what you should do if your medical team is asking you to tell them which one is the best donor. You cannot do that. But because we all knew numbers, those are the numbers that we use right here. You can take a snapshot if you want. The B cell size is directly related to what Chris Wiebe and Nickerson showed us to be significant. And on the right, on the left-hand side is what we use for PIRCHE score that derived from a bunch of papers. But remember, there is always a risk. In fact, each category, low risk, moderate risk, and high risk, please note that they all contain the word risk. There's always risk after low, moderate, and high, which means you always have a risk because you are crossing differences, and the immune system is created to detect those differences. Clinical application, all good stuff and all good slides and animations, but if you're gonna apply it in real life, what is the need for it? So two buckets. We all know we have the living donor buckets, we have deceased donor buckets. There are a bunch of stuff that we are studying. For the living donors, is engineered transplant to be in fact low eplet mismatch and low T cell mismatch. And for both, there is an interest in figuring out whether this is informing us about individualized induction, reduced immune suppression, and of course, individualized treatment after transplant, because those three things, the induction, the suppression, and the way we monitor, it's blanket statement, right? We do the same thing with everyone with disregard of what is the immunological difference here from our patient to patient. Now, unless you work with Karim Murphy and you have like the largest pool of donors that I know short of what is in Saudi Arabia, we do, no one of us has enough as a single center, as a pool, a large pool enough for donors where you can swap around to do that. And so the best way is to join a shared network, because you increase the donor pool and so you increase the probability of finding what you're looking for. Now, important, the donors, because this is also another myth out there. The donor are selected based on the same rule and principle they have been used in transplantation from forever and by center-specific standard of care, right? So under no circumstances, I believe that a donor should be selected only on the basis of the high molecular or low molecular mismatch, right? The same things that you have used every day still needs to apply. So the first step in these networks is that out of all the donors that you have, you select, the medical team select the donors that are medically and surgically okay for transplant. In other words, this is a bucket of individuals that you can use as donors no matter what. You can close your eyes, throw a dart with that sticks, that's your donor. At this point in time, on this cured population of donors, you create a bucketing of compatibility and say, well, this group right here is low to zero to low, this is moderate, this is high, and whenever possible, you transplant patient in that group on the left-hand side because it's zero or low. We don't have that group. We team up with the National Kidney Registry. In 2020, we launched this venture. They call it Kidney for Life. And you can see from 2020, the sharp increase on transplants that are engineered to be low or zero molecular mismatch. I just want to point out that the two different colors, where blue is incompatible, but green is compatible donors. They are decoupled in purpose to create a better transplant. And one of the things that was there to us is whether or not this increases the time to transplant. You can see here, I want to please focus on the red line, which is the recipient with ABO, and you can see that more than 50% of them are transplanted within 2 months of activation in the NKR system. So it doesn't look like there's impacting that. On the deceased donor side, one of the most important thing that was the first thing, the light bulb that came out from the initial paper from Chris Wiebe was, can we decrease suppression in a safe way? So we have a clinical trial in progress. We are all past halfway the end, where if a patient is transplanted with either diseased or living donors, there is low eplet mismatch according to the Chris paper, the single molecule, that 90 days post-transplant, the TAC is decreased to 5.6 from 8 to 12. And then we monitor like whether this patient develop rejection. Now, this is an active NIH clinical trial. I cannot show you data, but I certainly can say that it looks very, very promising. So hopefully soon we'll show you the outcome, but it does look very promising. All right, want to finish up with how do we use this in every day? How is Doreen and I interacting with this system on a daily basis? So on living donor space, every time we have a virtual cross match, we do molecular compatibility by PIRCHE-II, PIRCHE-B, and eplet mismatch with the eplet mismatch registry. Please do not use outside calculators. If the donor has a favorable molecular score, so it is low or zero, the recommendation for the medical team is to proceed to direct donation here internally at NYU. If it's unfavorable, there is a discussion on swapping and using NKR, and of course, some patients are okay and donors are okay, some they are not. Of course, nobody forces anybody to do anything in particular. On the disease donor size, we do molecular compatibility at time of virtual cross match when we smell, when we think that it's more likely to be zero and low. And both Doreen and I have done enough calculation that we can spot someone that is going to be like zero low. In the case we do it, and we do it also, we look at it also if we have one donor and multiple candidates, right? And you know, on top of doing the regular virtual cross match, we say, hey, and on top of it, if you can choose and there is no impact on the individual because they are all otherwise equally by any means medical surgery and probability of finding another offer, this one has less mismatch than this one. Molecular compatibility will be done and is done by all these methods if the medical team wants to decrease suppression, because they have to do so. So the medical team connects with us and say, hey guys, can you calculate the molecular compatibility? So that rather than saying like, oh, I feel that today 5 is gonna be okay, they do that with a much more scientific background. If a different induction has to be done for whatever reason, that's the same thing. We calculate the differences to know what is the probability of activating T cells. We do PIRCHE-T memory for retransplant. And ramp score, as I was telling you, is to determine a probability of favorable organs. So if somebody's going to ask you, like, what is the probability for this patient to have a low molecular, you can ramp it in the population and see what it is. For all donors, we are actively researching these 4 major areas. Reducing immune suppression is very important. There's a clinical trial ongoing for reducing immune suppression. We all use a lot of belatacept, which blocks the B cell crosstalk in the germinal center. But what if the patient has either T that is very low or B that is very low? Do you need to use the same amount of beta? So this is in the planning phase. And we want to see if there is any logic, which is in progress and in planning phase, to figure out what to do in terms of how frequently do you monitor your patients and with what, based on the molecular differences. So molecular compatibility, I hope I have at least put a little pin in your brain about the fact that this is a better biomarker to quantify differences, and it's predictive of how the transplant is going to go. What is the outcome? Don't have to love it, but you can't deny the evidence, right? And I know that is always, I don't think I will never hear we need to do more work. Yes, we need to do more work, but I think this is an excuse to not support your medical team by providing the information that they want to give a superior quality of care for what you call your patients. And with this, I want to thank you for your attention. I'm ready to take any question. Thank you.
Thank you very much, Massimo. Yeah, we'll open it up to questions. I see we've already got one in the chat, which I think you partially addressed, but maybe just give you another chance to do so. And then I see Dr. Halloran's already got his hand up. But first, from Dr. Aziz or Aziz Shentufi, would you replace in the future DSA and virtual crossmatch by the PIRCHE prediction scores?
No, I don't think I can, because there is no certainty that because you have a mismatch, you will have generation of DSA. So you still need to do that study, you know what I mean? And you still
Exactly.
need to do the virtual cross-match. Yeah.
Yeah. Okay, Dr. Halloran, please go ahead.
Okay. So I really enjoyed this talk. I thought it was brilliant. I appreciate all the work that goes behind it. In my mind, we're thinking about two different mechanisms for graft injury by the allo-immune response: the effector T cell generation and the unit of NK and antibody. Can you separate those two risks? Can you separate the factors involved in effector T cell generation from the risk of making a high affinity IgG and therefore activating NK cells?
By score, you can, right? By score, you can calculate the B and you calculate the T. I don't think it's the right method, because the generation of the antibody depends on the activation of the T, right? It's T cell dependent, right? So I think you shouldn't split. You can say that from the T cell standpoint, I don't know, DR17 has more eplet than mismatch eplet as compared to DR1, right? So you can find a potential more juicy antigen, right? But the final step, which is the generation of the novel DSA, I don't think is something you can really completely split. And also, even if you look at the last step, right, in the germinal center, when the T cell and B cell cross-talk, it is dependent by a peptide that is presented by the B cell to the T cell, right? So if that is not efficient, then you don't have efficiency, right? I mean, Lanzavecchia was showing that you still create a T cell response, you still create antibody, but you need a huge, much larger 10 to the 4 more antigen to reach the same level of activation as to when the cognate T and B cells meet each other. So in terms of scoring, yes, you can say, like, if I would have to have two donors, right? And one of them has like the donors are both homozygous, right? To DR, right? And one DR17, the other is DR1, and DR17 has more mismatches at the eplet level. Then yes, I can say, there is more risk right here than there. But when you look at the final product, the DS, I don't think you should split it. That's
Well,
my opinion.
let me refine the question.
Yes.
Is the T follicular helper cell generated against the same epitopes as the effector T cell that goes into the graft and causes T cell mediated rejection? In other words, is help generated through the same epitopes by the T cell? Do we know
So
if the repertoire of the T follicular helper cell and the effector T cells in the graft is the same?
I don't know if a study has been done in terms of T cell, right? T cell receptor. The idea is that for the helper to tell the the CD8 T cells to go find a peptide in the organ presented by MHC class 1 this time and do something about it. So the peptide might actually not be the same, right? Because the first one was done by MHC class 2, right? So the peptide is presented by class 2. And the T cells recognize a peptide that is presented by class 1. But PIRCHE has a PIRCHE-I module where you can calculate and estimate the probability of T cells, CD8 T cells, to see peptide of interest from the same mismatch HLA molecule. So the one I showed you was the PIRCHE-II. So it's the activation of CD4 T cells with the central core of the immune system, right? If you mess with the CD4 and the activation of CD4, you turn off the entire immune system, which is what HIV does, right? But to be that specific, you can do the PIRCHE-I score and learn from each and every one of the mismatch HLA antigen and what is the contribution in terms of CD8 T cell recognition. You could do that.
Thank you.
Yes. But it would be nice to have a like in situ study to look at the T cell rearrangement and prove it. Yes, I agree with you.
Okay, thanks, Dr. Halloran, for the question and Massimo for the answer. We just have one, we're at time, but I see one other question has just come up. In case of positive DSA, how can the molecular mismatch risk help in donor selection?
So if I get the question right, there is a DSA, right? So if there is a DSA, there is already a risk. So I would not. The molecular mismatch is at this point is another problem, right? Because you already have a physical detected antibody that can hurt the organ, right? So perhaps the way you need to see this, like the the molecular mismatch can help you assessing the risk and probability that your patient will develop DSA in the future, mostly for non-compliance, or in cases in which the patient develops an infection, compliance needs to be decreased. I mean, suppression needs to be decreased, and there is a probability. So it's kind of the other way around.
Great, thanks. Okay, I think we'll close there. I don't see any other hands up or questions in the chat. So thanks again, Massimo, for joining us today. It was a great talk.
Thank you so much.
Yeah, and just a quick note about next week's seminar will be delivered by Dr. Ryan Alandari from Dr. Jayan Nagendran's group. And the title of his talk will be Ex Vivo Lung Perfusion at the University of Alberta, Past, Present, and Future. So join us next week for that talk. Thanks so much, everyone.
Thank
Enjoy
you
the
again
rest
for
of
the
your day.
invitation.
Thank
Bye. Bye.